A very good afternoon to everyone. Welcome to yet another series of clinical case studies where the platform is open for both medical fraternity and the dietetic fraternity, where both a doctor and dietitian comes together and discuss a case study. So today we have a very interesting case and a life-threatening one and something which is very painful to see. It is TEN, which is toxic epidermal necrolysis. Uh, See, we all depend on pharmacology, medicines for our illnesses, infection, or it could be anything. But imagine a situation where the medicine itself becomes a life, gets us into a life-threatening situation. So TEN is yet another case like that. It is a smaller form of burns. So when it goes up to 30% of burns, it is called as TEN. Everyone would be aware of SJS. So this is an extended version of SJS. To explore more on this, how the medical expert has dealt with the sensitivity and the medical aspect of this case, we are going to invite Dr. Pooja. She is from Fortis Hospital, Banerghatta Road. I would request Aisha to please share her CV slide. Aisha, can you please share the slide of Dr. Pooja? All right. Okay, so we have Dr. Pooja Pratapan Sarada. She has been in critical care medicine since 2010. She finished her MBBS from Jipmer Pondicherry in 2002. She finished her MD anesthesia from Government College Thiruvananthapuram in 2008. She finished her fellowship in intensive care medicines from Sri Jayadeva Institute of Cardiovascular Sciences, Bangalore, 2011, and did her IDCCM, which is Indian Diploma of Critical Care Medicine from Fortis Hospital, BG Road, and EDIC, which is European Diploma in Intensive Care Medicines in 2015. She's also trained in the Royal Adelaide Hospital, which is from South Australia, and she is presently a teacher for students for IDCCM and DNB critical care doctors. And she has contributed in multiple publications in journals. She has authored in the critical care books, and she's been a part of national and state level workshop. And she has her special interest lies in critical care, ECMO, and infectious disease. And she works as a senior consultant in MIC in Fortis Hospital. Apart from all this formal introduction, she's a very creative person. In this era where there's more of misinformation than information in the social media, she creates very creative reels on medical sciences, educating a common layman person. So I'm very happy to welcome Dr. Pooja. Are you able to see? Aisha, are you able to see the slide?
Yes, the slide is visible. Switch on your camera, please.
Yeah. Is it moved? Yeah, 1 minute. Huh? Yeah. Yeah. Hello, everyone. I hope I'm audible. And shall I proceed?
Yes, doctor, you are audible, and the slides are also visible.
Excellent, excellent. So, good afternoon, everyone. So, the next 20 minutes, let me take you through the medical aspects of one of the organ failures, which we don't see it very regularly, rarely, but it's very important. And as dietitians, you have a lot of importance and a big role in to play in the management of this patient. And we are talking about the organ. You'll be surprised, it is skin, okay, and not any kidney or liver failure. It's called acute skin failure, and the disease that I'm talking about is called toxic epidermal necrolysis, okay. And see, look at the photos here. So this is the initial stages of a drug rash that developed. It progressed into, these kind of rashes where there is a central pigmentation. If you see, there's some amount of blistering has already started. If you look at my arrow where I'm showing, blistering has started. Then started the skin peels, more skin peels, and then there's involvement of the mucosa. Mucosa can be from oral cavity to the anus. The entire GIT mucosa can be involved. Wherever mucosa is there, like the eyes, the inside the auditory meatus, everywhere can be involved. And now look at this picture. And this is not toxic epidermal necrolysis. This is a condition, burns. So almost similar. If you look at the pictures, the skin peel, when it comes to skin peel, it looks almost similar. That's why I want to highlight this, the difference, TENS and the burns, the difference and the similarities. All right. So what is this epidermal necrolysis? Now it is a rare, but it is a severe and life-threatening mucocutaneous. It's a hypersensitivity reaction. It's a type 4 hypersensitivity reaction, and it is predominantly drug-induced. And it is characterized by widespread keratinocyte apoptosis. Keratinocyte apoptosis means cell death, and that leads to skin detachment. So it is also called acute skin failure. Okay. Now we have a spectrum of this acute skin failure where you have Steven-Johnson syndrome, or SJS that we call, where only 10% of the skin is involved. Then you have an overlap between SJS and TENS where 10 to 30% of the skin is involved. And you have TENS, which is a toxic epidermal necrolysis, where more than 30% of the skin is involved. And you look at the mortality, how it is increasing from SJS, where the mortality is only 4 to 10%. It goes to 20% and it goes up to 50%. So very few diseases have this 50% mortality kind of thing, and TENS is one of them. All right. Now the body surface area is very important. That's what we said, the 10 to 20, more than 30%. And how do you calculate the body surface area? So we go back to burns, and that's when we derive it from there, the rule of 9. Okay. So the rule of 9 is how we determine the body surface area involved in TENS. So the front part of the body is 18%, back of the body is 18%, each leg is 18%, each upper limb is 9% each, face is 9%, and genitalia is 1%. So this is how we calculate the burns percentage, and this is the same way that we calculate the percentage or body surface area involvement in cases of TENS. Now the incidence 1 to 7 million per year, mortality up to 50%, and it can typically happen between 4 days of exposure to up to 28 days of exposure. And once this happens, the person loses almost 9 years of his life. Okay. How does it progress? So usually it starts with like a viral prodrome will be there, fever will be there, malaise, pharyngitis. That's when people, think it is a viral infection, and they do not come to and take help. Skin develops macules, vesicles, blisters, and then they start getting detached like sheets. Mucosal involvement. Mucosa from the mouth to the anus. Entire mucosa can get involved. Ocular. The eyes, pseudomembrane can form, defects can form. Nikolsky's kind. Nikolsky's kind is when you touch a skin, you put a little bit pressure, the skin just comes off. Okay, the skin just sloughs off. That's called positive Nikolsky's kind. And then there is systemic involvement also. So this acute skin failure is not just limited to the skin. It can cause severe sepsis. It can involve lungs and cause ARDS. It can cause renal failure in severe cases. The gut is very important in TENS. Why?
because see, these are the complications that you see in TENS. It can be acute complication. It can lead to also chronic because the mucosa is involved. So chronically also, lot of complications can develop. Strictures can form. Okay, the diverticular sacs can form, abscesses, pseudomembrane formation. And this can happen in the later stage, chronically also, like 1 to 2 years later also. Acutely, there can be diarrhea, GI bleed, vomiting, luminal erosions, all those things. So that's why gut is one of the most common organs which is involved in cases of TENS. Now, what happens in TENS? How does this happen? Okay, so mainly there is a drug, or the drug metabolite is a trigger. So this here you see drug. So this is the trigger, and it is presented with the protein to form an antigen. And this antigen, it goes and binds to CD8 cells. So basically the entire emphasis is here on CD8 plus T cell activation. And it can happen by different methods. This Hampton model, the pharmacological model, the HLA model. Eventually, what it does is activation of this CD8 T cell lymphocyte. And once this T cell gets activated, there is a release of all the cytotoxic mediators. Okay, and these cytotoxic mediators, they will cause keratinocyte death. Okay, by either apoptosis or necroptosis. Why this HLA is important over here is because this HLA1 methodology, it tells you that there could be a genetic predisposition also, especially in the Chinese population where these kind of HLAs are found. Carbamazepine, those people in Chinese population are more prone to TENS or SJS when they take carbamazepine. Okay, so this is just a pictorial representation of what happens. Basically, the drug or its metabolites get presented with an antigen, goes and activates the CD8 cells. CD8 cells will release all these immune cytotoxic molecules, and that will eventually go and cause death of the cell. The two methods, apoptosis and necroptosis. Apoptosis is basically cell death. Okay, but necroptosis is cell death along with necrosis. So that is what leads to the inflamed or the severe inflammation that you see, okay, in TENS. So I hope you have understood the pathophysiology. So this is an immune mediated reaction, unlike burns where it is mainly mediated by a heat mediated injury. Here there is no heat mediated injury. It's mainly CD4 cell activation, and entire thing is immune mediated pathway. And that is why the treatment also will be directed at these immune mediated pathways only. Now, the risk factor, if you see 90% of the time, it is caused by drugs only. And it can happen from 4 to 28 days post-exposure. So these are the most common drugs that are involved. One is the anticonvulsants. Anticonvulsants, carbamazepine, lamotrigine, all of them can cause SJS. And in antibiotics, that's why over-the-counter drugs, you should be very careful while taking. The sulfonamide antibiotics, they have a high chance of causing SJS and progression to TENS. Allopurinol. See, allopurinol, mainly in cancer patients, they will be on to prevent hyperuricemia, they will be on. And these newer anti-cancer drugs which have come and which are right now more than the chemotherapy, these immune checkpoint inhibitors and targeted therapies are more important. They also can cause SJS TENS. So that is why we should know what kind of a patient that is. Is the patient coming from the community with no other comorbidities and just some infection and they decided to take an antibiotic, or somebody who has been on some anti-epileptics and they took that, or is the patient a cancer chemotherapy drugs? Now the rest of the 10% is by infections, mainly mycoplasma and the viral infections. Now, how do we prognosticate this patient? So we have different scoring. One is the Schotten scoring. So Schotten scoring will tell you what is the mortality with this SJS TENS that you have. So Schotten scoring at admission we do, then we do it after 3 days, and then we see the progression of the score. If the score is worsening, that means the patient's mortality also, that means the patient also is worsening. In another one we have is the Kristen. So Kristen is a Japanese score. So here you don't have any lab parameters. So as soon as the patient comes and you don't have any lab parameters in hand, you can predict mortality with the help of this Kristen score. But in our hospital setup, because we have the lab values, everything, we usually use the Schotten scoring. Now, Schotten scoring, they also added something called the Re-Schotten. Re-Schotten, additionally, what they added is this red cell distribution width by hemoglobin ratio. So that increase the accuracy of Schotten. But still, for us, it is easy to follow the Schotten scoring, and that is why we do that. Now, what investigations do you do? So the gold standard is skin biopsy. So skin biopsy, when it is done, it will show a lot of subepidermal bullae and this T cell infiltration. Why do you need a skin biopsy? You don't need skin biopsy in every cases. So most of the cases, when you know a patient took a drug and after that he developed a reaction and that is how it progressed, we generally don't do skin biopsy because we know that this is this only. But in cases where the patient has other existing diseases like graft versus host disease, pemphigus, on top of that the patient has come with a worsening where you want to rule out or rule in SJS, that's when you can go ahead and do a skin biopsy. Other than that, we do the usual CBC. These patients can have anemia, and this is something which we keep doing over the days also, the CBC. Then in biochemistry, you have the Bun, creatine, glucose, AG, LFT. Our nutritional markers, usually albumin. This based on micronutrients, it is very difficult for us to, because the lab limitations, we generally don't do. We know what is going to happen to them in these kind of patients. And phosphate, potassium, magnesium, this is something that we regularly keep checking. Infection monitoring with the help of CRP, procalcitonin, culture, skin swab. Biomarkers, generally LDH and CRP is what we do. Other than that, we do not do any of the biomarkers due to non-availability. And urine analysis, basically to see whether there is cast that is causing acute kidney injury. So these are the investigations that we do in the first setup, and many of them we keep repeating doing because there's a lot of changes that happen in these patients over the time in these lab values. Now, this is the skin biopsy picture where you can classically see the epidermis. It has been lifted up, it is detached, and under this is the bulle fluid. So this is one of the findings, and these blue things are all inflammatory infiltrates that you're seeing, and this is what you're supposed to see. And these classic findings will only exist till the second degree of burns. But you see how the burns is going. The burns is extending below layers, going down and down, going further down. But that you do not see in TENS. In the TENS and SJS, you see it is very much limited to the epidermis and the dermal layers. And that is what up to the second degree burns is what similarity we see. And in burns, you don't see this much of inflammatory response, the T cell and all those things. That you see only with in SJS and TENS. So that is one of the differences. One is heat mediated, one is purely CD8 T cell mediated. Okay. Now, specialist assessment is very important, and within the first 24 hours, we get the ophthalmologist into our ICU because they need to evaluate the eye and they need to do a lot of preventive measures so that the eye, the cornea, there's no synechia formation and everything is managed in a better way. These patients are, every second hourly we put eye drops in these patients. Okay. Next is ENT and respiratory only if needed, if there is any obstruction further down because of fast formation and all, then we get. In female patients, gynecology is important because vaginal stenosis can happen. Sometimes you need to push in paraffin wax gauze into the vagina so that the stenosis is prevented. Gastroenterology, if and when needed, when there is any melena, we are suspecting upper GI bleed, then you need. Sometimes you might need them to put a NJ feed endoscopically, then you will need them. Dietary, nutrition, very important, which we will deal in some time. Psychiatry, yes, it is very important. It is not easy to see yourself and your skin and your face getting deformed in such a way. Okay, we have had one female patient who, after in the second week of in the ICU, she started showing us the photo to make us believe how pretty she looked. Her past photo, she started showing up. So this is a lot of traumatic stress disorder can develop, and there's a lot of anxiety whether they will get back to how they used to look earlier. So psychiatric and psychological counseling is very important in these patients. Basic supportive care. So these patients we usually maintain in isolation because sepsis is how they die. So we don't want any new infection in them. And we are very careful about starting any antibiotics in them. So we do not want any infections basically. So they are isolated. We keep them in a positive pressure isolation so that we do not allow anything from outside to come inside. Okay. Temperature regulation. You lose so much of skin. Skin is one of the organs which helps to maintain your temperature. So we have to keep the room temperature a little bit higher compared to other rooms, like 28 to 32. Airway, these patients can quickly develop an obstruction of the upper airway because of the mucosal edema and all. So every time we keep assessing, we speak to them, whether the voice is coming or not. Anytime we feel that there is gurgling, they're not able to speak, we electively intubate them early, because later when the swelling happens, it becomes very difficult. We might end up with an emergency tracheostomy. Fluid management, very important. We'll come to that. We do not go by the entire burns protocol kind of a thing. For us, it is 30% lesser than what happens with the burns. Nutrition with the nasogastric tube, which we will again discuss. Wound care is very important. We usually use non-adherent dressing. Unlike burns, in burns, importance is given to quick debridement, going to the OT, cleaning up, debridement, then the grafting, all those things. Those are not done in SJS and TENS. Those are not there. It's just the wound care with non-adherent dressings. And strict infection control. You don't want any bacteria, additional bacteria entering in them. Unfortunately, the case that we will present did end up with a secondary bacterial infection in spite of all that we did. Okay, so this is one of the photos of the patient that we had. If you see these, the white things on the back, they're all this the lotions, which emollients, which our dermatologist prescribes. These are non-adhesive dressings which are there. If you see, we have also placed a center line for this patient because IV access is difficult. Where will you see an IV a vein in this kind of skin? And this is what we use for on the bed for the contact surface. We use autoclaved banana leaves. It is cheaper because we have to keep changing it multiple times, and we have found that in an Indian setup that helps a lot. So we use autoclaved banana leaves on the back. So water loss. Normally the skin loses almost 400 ml per day. But in here, what happens? The skin is gone. So there is a loss of transepidermal water. And also there is a lot of transpiration also occurring. So it's not just 400 ml per day. It exceeds quite a lot. Then there is blisters. So these blister fluids will have a lot of sodium, potassium, and chloride. So that is also lost. Phosphates are lost. So all these things basically will alter our neurological status, drive from function. So quite important this water and electrolyte balance. So they can be either wet type or dry type. So some people will be very oozy. So those people will lose more fluid and electrolyte compared to dry. The dry will be losing more of skin. So that means they will be losing more of protein. So that is the importance of fluid. So how do you calculate fluid? So in burns, we use the modified Brooks formula in the first 24 hours. But this is not exactly burns. You can like a subset of a subset kind of a thing. So we generally take 30% lesser than what we give in burns patient. Okay. And the fluid of choice is usually crystalloids. But sometimes these patients, their albumin start dropping. The albumin will be on the lower side. And when you have to give them a lot of fluid, we do add albumin in the later stages. Or if there is shock also, along with crystalloids, we supplement albumin and give. We monitor the urine output. We would prefer 0.5 to 1 ml per kg per hour. We generally use a center line because getting an IV access is very difficult in such patient. Maintaining an IV cannula is very difficult. So center line is preferred. Vasopressors, the standard protocols only we follow. And we guide the fluid based on lactates. Is the patient continuously febrile? How much is the urine output? Is there a mucositis and diarrhea? And we use a lot of ultrasound parameters to guide fluid in these patients. Wound care is very important. I showed you the photo, a lot of petroleum jelly, chlorhexidine sprays, blisters. We just drain them by a needle prick. And there's no debridement or grafting like you do in the burn patient. Ocular care is very important. Every second hourly, some drop will be there in their eyes. GI and mucosal care. We try to place nasogastric tube a little bit early because once the crusts start forming, placing a nasogastric tube will induce a lot of bleeding. Okay, so we would preferably try to put a nasogastric tube early, and inevitably most of them will not be able to take the oral adequacy will not be there because of the blistering and the ulcers. And genital and ENT care. Now, what do we treat with? Now, if you look at the pathophysiology, like I told, it is all immune related. It's all CD8 T cells. It is not heat-induced injury. So what you need to do, you need to suppress the immunity. And how do we suppress the immunity? We use corticosteroids. We pulse them. We give the steroids. Second thing is cyclosporin. Now, recently, this current patient, we use cyclosporin as the first line. And it's actually coming up as a first line agent also. So that will also helps to settle your it is T cell selective inhibition. Then you have the TNF-alpha inhibitors and all, which we have not started using because the first two line drugs, which are there, steroids and cyclosporin, they are important and they cover most of the time. Okay, IVIG also has been used, but in first line is steroids and cyclosporin. Now, long-term sequelae, yes, the skin will have a lot of issues. Eye issues will be there. Oral and GI issues will be there. So there are a lot of follow-up required with these specialties even after the patient gets discharged. And this follow-up will be needed up to 1 year. Okay. Now, why nutrition is critical in SJS? So oral intake, it's because of severe mucosal erosions, it is impossible. It becomes very less actually. And it is the nutrition that starts healing. So we control the inflammation by medicine. Nutrition is what heals these patients. Okay. In these patients, resting energy expenditure goes up 20 to 50%. Without treatment, your mass lost is 1 kg per day. Higher mortality, if nutrition is not covered, mortality increases up to 3 times more. And every percentage of body surface area involved, 2 gram of protein requirement, it keeps increasing. Okay. So how do we calculate the calorimetry? See, calorimetry, we don't have indirect calorimetry, so we do not do that. The formulas that is used in the burns, the Curry formula that overestimates, we just go by the body's predictive formulas, which is the body surface area adjusted rule. So that is what we follow. And we also start with the hypocaloric, and then we start building up. By the end of 1 week, we hope that we are able to at least achieve the targeted 70 to 80% we are able to achieve. Now, we try maximum to start feeding within 6 hours of admission to the ICU. Fluids, I already discussed. Oral or NG, whatever oral is possible, we give, but it will be extremely inadequate. So a nasogastric tube is something that we generally follow. TPN is only when our enteral route is closed. We are not able to do because of multiple reasons. We are not able to, then only TPN comes up. TPN comes up with also its own problems. Okay. Now, it will be a carbohydrate, the non-protein calorie to nitrogen ratio, almost 150:1. We need a positive nitrogen balance because we need a lot of healing in this situation. So positive nitrogen balance is important. And here there is a lot of role in extra vitamins, trace elements, and probably glutamine also. So which we do not see in other kind of patients like respiratory patients or ARDS, COPD, sepsis patients. Okay. So what to anticipate when you're feeding these patients? These patients, since the skin and dermis goes, there's a lot of hyperalgesia. So we put them on a lot of opioids. They can be morphine, they can be fentanyl, and these end with a lot of ileus. Second thing, steroids. If patient is on pulse steroid, hyperglycemia will be there. So the feed needs to be modified accordingly. These patients, sometimes they come late. So all this time they wouldn't have had any food. So they will be all at risk of refeeding syndrome. Then you see there's a lot of cancer patients also involved. So they are also at risk of refeeding. Okay. So these patients, you need to start with all of you will know how to prevent refeeding syndrome. I will not go into that extent. So monitoring the electrolytes, make sure thiamine is given, make sure the phosphate is adequate. So that will help. Next thing is ongoing diarrhea. When there is mucositis, diarrhea will be there. And then the issue of the protein that will be, 1.5 to 2 grams per kg also, which we need to provide. And ongoing protein loss when there is ongoing diarrhea. So there is a lot of stress on how to provide this much of protein in these patients. Now, nutrient loss, when the skin sheds, there's a lot of iron and B12 that is lost. Also, absorption problem is there. Cell turnover is more, so folate also is deficient. Selenium, zinc, iron, E, C, all those becomes very important in acute phase of this injury. Now, why do these patients develop hypoprotein? So whatever you try to give, eventually you will see that there is some amount of hypoalbuminemia happening. One thing is the liver decides, okay, this is an acute phase. I will stop producing albumin. I will produce acute phase reactants. So there is less production from the liver. Next is demand. Obviously, there's a EMR is there. There's a high demand state. Then there is a lot of loss through enteropathy, shedding of the skin, increased catabolism. So that is where the protein goes in these kind of patients. So these are the supplements that we would suggest in these kind of patients. There is no actually data regarding SJS, how much you should. There's a lot of data in burns patient. Okay. And we always extrapolate from or actually underpolate from the burns patient because a lot of things are similar in these two kind of situations. Okay. So we exactly don't have much, evidence-based data on how much to give, what is to be given. So always we underpolate it from the burns guidelines. And this is actually the Directorate of Health Service guidelines 2025 regarding standard treatment guidelines of management of burns as to how much should be given. And dietitian role, like I said in the beginning also, this is a disease where it's very important in the acute phase, the stabilization phase, and the recovery phase. Recovery phase is obviously when they go out of the ICU, but in the acute phase, how to prevent refeeding, how to establish that the micronutrients are going correctly, how to establish there is a positive nitrogen balance, fluids, and by second weeks, how to achieve the target in spite of the diarrhea and all, how to achieve, do we need to change from NG to NJ? So all those things are in the stabilization phase. And obviously recovery phase, you will have to stop your NG and go back to your oral. So there also, so the entire phase of this SJS and TENS, the role of dietitian is very important. Like I said, our drugs will stop the immune process, but the recovery is mainly because of what is given to the patient, and the nutrition is highly important in this scenario. Thank you.
Thank you so much, Dr. Pooja. It was so very comprehensive. You have covered all the aspects of the nutritional, the medical part of it. I'm sure since this is a new case, people will have a lot of questions, but we'll take the questions at the end. So we will be now having the presentation from our clinical dietitian, Tulsi. Okay. So Miss Tulsi has she has around 15 years of experience, and she's been in Fortis Hospital since 10 long years. And she completed her post graduation in clinical nutrition and dietetics from Alfonso College, and she's a member of IDA and IPN. She has immense experience in all the fields of hepatic nutrition, renal nutrition, cardiac nutrition, malnourished, right? And and she has been training quite many new interns, new dietitians, has an immense lot of experience in that. I'm happy to invite Tulsi here. Guys, we are all doing in the same room, so you may see little shiftings here and then. All three of us are doing from the same room. So on and off, you'll be seeing us on and off the screen. I'll share screen for Tulsi. But where is the PPT where to open? No. Just a minute, we are sharing the slide. Yeah, but let first our PPT has to come. Presentation. I have opened, no? Yeah, this one. And video to be switched on. How do we go? And one minute. Yeah, I welcome Tulsi here. Come, Tulsi.
Good evening, everyone. Many thanks to Shalini ma'am for the introduction. And Pooja ma'am explained detailed about the toxic epidermal necrolysis. So I will directly go to the nutrition part. Hope I am audible.
Hi, Tulsi ma'am. Yes, you are audible.
Thank you, ma'am. And first patient profile, actually she admitted in the ICU. She is 41 years, female patient, and we did assessment. During assessment, I take the history. I got to know she was very active in her community, and she was doing participated in many cultural activities, and she's also a health conscious. And this her BMI was normal, and we did SGA, subjective global assessment, and nutritional score came as severe nutritional risk because she was in hypercatabolic state because of Then chief complaints was presented with, she admitted with fever with chills since 3 days associated with burning micturition. She was evaluated other hospital and she treated the same with antibiotics, and later she developed rashes, swelling of the face and neck, and after 2 days she admitted in our hospital. Past history was nothing significant. All other parameters was normal in physical examination. But in local examination, papillary rashes, skin peeling of eyes, face, mucosal surface of mouth, palate, lips, neck, anterior chest, and abdomen was found, and diagnosis was done as toxic epidermal necrolysis. As ma'am explained the Scotland in detail, so I'm not going in that. And her biochemical parameters was slight changes in albumin level. As ma'am explained, in albumin can reduce, level will decrease during inflammation or infection, even if nutritional intake is adequate. Protein losing entropathy can happen, so it can reduce actually. And also in sodium also was a slight variation was there. Fluid calculation, we have to cross monitor the this sodium potassium electrolytes, we have to cross monitor. And also because of infection was high, her WBC count was high initially, then slowly it was normal. Then coming to medications, first treated with immunosuppressant, that is used for it. In this case, it helps to reduce uncontrolled immune attack and further epidermal destruction. I mean infection. Then also other supplements we could give, we given this condition. That is, first is neurobion fort, that is vitamin B complex supplement used to prevent and treat vitamin B deficiencies. And SIPME9 syrup also given, because in this case zinc is very important. That is the trace element that have 9 essential trace elements including zinc. Other medication is there, but I'm not going in that. And coming to medical nutrition therapy, nutrition is an integral part of management as SJS and TN is a hypermetabolic state. In this case, glycemic control can be a problem as a result of stress. But this case, I could notice that we were close monitoring the GRBS, but her sugar level was normal in her hospital stay. Then the calorie and protein requirement increases with mucosal and skin damage and is estimated to be around 30 to 35 kilocalorie per kg body weight, and 1 gram to 2 gram protein per kg per day also. According to ESPN guidelines, we calculated that. Then also, initially she was
Can see. 1 minute. Any idea till where you could see? Do we have to share again? I have to share again, right?
Yeah, please share the slide once again.
Yeah. Sorry, everyone. I think there was some glitch. Automatically, we logged off without our knowledge. Just give us a minute. यहाँ पे presentation कहाँ गया? आपको पता है करेंगे. Just ये presentation के लिए
शेयर स्क्रीन हो गया.
किया. Yeah, first wish.
From where?
We can put it in the mode and we can go later. You are able to see the slide now? Aisha, are you able to see the slide? Comes the slide got locked up. You want to see the slides? No, it got locked off. We have gone again done. Let's see. We have logged in again, but
Yeah, I can see the presentation.
slides are there. You are able to. 1 minute. Can
Yeah.
1 minute? Can you share? Slides. She says she can see. We can go to the presentation. This one. No. Yeah. Any idea of till where you had from where we got dropped off? Probably we'll start from.
Yes, from this slide.
Okay, from MNT you can start to see.
So sorry for the inconvenience. So I will start again. This nutritional support is crucial in TN patient due to the hypercatabolic nature of the disease. So first we will start the compared to TPN, enteral feed is better option. If oral mucosa is significantly affected, nasogastric tube may be used. And about fluid, ma'am has explained. In the early stages of disease, when dysphagia and odinophagia are severe, a fluid or semi-solid diet is preferable and better tolerated by the patient. Early and continuous enteral nutrition decreases the risk of stress ulcers, reduce bacterial translocation and enterogenic infection, and allows early discontinuation of venous lines. Then TN causes severe damage to both the skin and mucosal membranes, including the mouth and GI tract. So semi-elemental formulas contain pre-digested nutrients, oligopeptides, and MCTs. This bypasses compromised gut and reduces abdominal pain and facilitates easier gastric emptying. Also, that helps to minimize digestive workload, allowing for maximum absorption of calories and essential trace elements directly into the bloodstream. And energy requirement and nutritional support must be carefully calculated. And my short-term goals was to meet hypermetabolic energy needs and achieve a positive nitrogen balance and support early wound healing. Also correct fluid and electrolyte losses and to provide nutrient-dense soft textured food to meet the increased requirement. Long-term goals was to prevent lean body mass loss, to promote optimal wound healing, and to avoid infection and sepsis, prevent nutritional deficiencies, and frequent follow-up with the patient. So we had calculated required calories as per ESPN guidelines, 25 to 35 kilocalorie per kg body weight per day, and required protein. It came approximate 108 gram, 1.5 to 2 gram per kg body weight. And fluid also we had calculated as per that equation, and that came up to 2430 ml. From feed also we could, from feed and IV fluids, we could achieve this much ml of fluid. And this is some picture of that patient. We can see the how it's affected her, and in hands and face, lips, mainly the mucosal area, it is more affected. And in case progression, day one, I told already, patient came with fever with chills, and from 3 days problem was there, and she treated other hospital and took antibiotic, and here she came to further management. Here first day echo was done, it was normal. We have started cold liquid diet, and day two she was not able to tolerate the fluid because of cold liquid diet, because of grade 3 mucositis. So inserted Riles tube. So we had started initially only semi-elemental feeds, that helps a lot, and she was able to tolerate feed throughout the hospital stay. And day 8, patient was tolerating artifeeds well. She had severe mucositis and eyelid edema, but all cultures were negative. Started semi-solid mashed foods along with artifeeds, but initially very limited quantity she could able to have. So many options we were given, but she was avoiding many options. Also, she was on immunosuppressant, so we had started neutropenic semi-solid diet. Then day 10, skin rashes improved and started getting dried. No new complaints. Immunosuppressant dosage also was reduced. She was on same neutropenic semi-solid diet and artifid. And day 11, she got fever and MDR was positive. So started with injection polymyxin. So she couldn't able to eat orally. So we continued with artifid. Day 17, patient improved clinically. Skin erosion started healing, and blood cultures came normal. Antibiotics were stopped, and in that she restarted semi-solid food along with artifeeds. In day 17 and all, she could able to eat 3 times in a day between artifeed semi-solid diet. So we gave many options like cold mashed foods, like curd rice, khichdi, kheer preparation, custard pudding, ice cream, etc. Then day 18, discharge plan was there. So I gave diet counseling, high calorie, high protein diet. And this was the protocol. First day clear liquid, and next day it was artifeed with semi-elemental formula. And 7th day we could achieve the maximum calorie protein with, we have introduced a polymeric formula also, semi-solid as tolerated. And so we could achieve the 2 gram per kg body weight protein as well, this calorie. 17th, she was able to tolerate semi-solid and both artifeed. And diet counseling was given. As the oral intake of the patient is poor, artifeed should be continued till the oral intake improves. And about the feed preparation and all, we explained clearly. Psychologically also, we given counseling to improve the oral intake, and many options we given, mainly avoid uncooked foods, outside food, etc. And also we told to include small amount of semi-solid between artifeeds, and factors to consider with regard to oral feeds are temperature, acidity, texture, and moisture of food. Hot, cold, acidic food and beverages worsen pain. So soft, bland meal is essentially preferred. So first follow up done telephonically. I had more interaction with her husband. So she was physically and psychologically affected more. So she was not ready to speak to me. So first follow up done after 2 weeks. Patient was getting better. Was tolerating the semi-solid diet. Trials 2 was removed. And second follow-up, also semi-solid diet with the polymeric formula we given. And second follow-up, after 1 month, patient was doing well. She was tolerating soft diet with nutritional supplement. Third follow-up, after 5 months, patient was tolerating normal diet with nutritional supplement, and she gained about 6 kgs of weight. Weight at discharge was 49 kg. And main thing in nutritional management, early nutritional assessment and prompt initiation of enteral nutrition and adequate, high protein, high calorie should be introduced, and correction of electrolyte disturbances, appropriate micronutrient support, and continuous monitoring and adjustment of nutrition therapy. These measures are considered as an essential part of multidisciplinary supportive care and are associated with improved healing and recovery. Thank you.
Thank you so much. Okay, thank you, Tulsi. That was dealt very, very sensitively. The case was quite neatly dealt by all the
Please
paramedics.
switch on your camera.
Yeah. Able to see me? Yeah, fine. So, yes, so since it was quite a unique case, so we do expect few questions. And since we are all doing from the same room, sorry, I would be able to get all the two speakers along with me, but I'll be, because I need to see the questions, but they are right here. We can hear them. So first few questions I have for Dr. Pooja. And this is, I know this is quite a rare case, Dr. Pooja, but how frequently do you see this? Have you come across many TEN cases?
You see, this is nowhere related to any infection, season, or anything like that. So it's a very unpredictable thing when it will come. It's like it's a type 4 hypersensitivity reaction. Okay, and it can happen anytime to anyone. We see 2 to 3 in a year. That's all. Okay, so there's no seasonal.
Right.
December mein jada more will come. Nothing like that.
Absolutely, absolutely. But it's quite scary. But
It is very scary.
okay, and. Okay, do you routinely use trace elements? Of course, see, what we give through the diet in the RT feed or orally may or may not suffice the requirements. So, what are the cases where you routinely use trace elements and vitamins?
We generally don't use routinely trace elements in all our patients. For us, concerning will be who have been in the ICU on the ventilator for a long period of time, who's nutritionally depleted and who scores high risk for a prolonged period of time. Such patients, we do try to supplement micronutrients and vitamins. And other thing is when somebody is on TPN, that will be additional category of patients whom we give. But it is not routine on a patient-to-patient basis on how much they have spent time in the ICU, how much of the nutrition they have been able to achieve goals. Based on all those things, we take a call on micronutrients.
Right, right. So do we treat the SJS and TENS as burns, or we understand it's a smaller version of burns, but for all the parameters?
Except for the etiology, everything, most of the thing is same, and also the depth. Right. Okay, there is a skin barrier is lost, temperature issue is there, infection issue is there, nutrition issue is there, protein loss issue is there. So all those things are almost the same, but the intensity of TENS is not the same as that of burns. In burns, what is happening is there is the amount of inflammation is excess, and there is third spacing is excess. The loss of volume is excess. That is why I said, like in burns patient, we don't go for the full 100% of what we calculated. we use that formula, but we go 30% less than what we give for them.
And I was wondering, see, when you said there could be detachment of skin, the way it happens in burns. So how do you take it? Does it happen in the retina also, on the eyes?
Not in the retina, but yes, the cornea is one organ which is significantly affected. That is why for day one itself, ophthalmologist is into the ICU. At least 5 to 6 drops are there, antibiotic drops are there, okay, and lubricants are there, and every second hourly some drop will go into the eyes because cornea damages. Many of them end with amniotic membrane. They need to transplant. They need corneal transplants. Many of them lose their vision. So it can end up like that. The care of the eye is very important. Eye is a very important organ.
True. And you also said there could be stenosis of vagina. Which etiology it leads to this?
No, it is basically, see, vagina is also mucosa.
Right.
Okay. So the mucosa, if there is erosion, okay, in that case, later what happens is synechiae. Synechiae is like the connecting, the tissues just get close together and they just form a synechiae. So that can happen, and that's how the stenosis happens.
Okay, so I think this is
Raw surface, basically raw surface.
Okay, so can we understand the same thing for small intestinal obstruction also, because you said it can happen even after 1 or 2 years?
Yes, these are the mechanical complications can progress. So beyond the ICU time, these issues can progress further.
Okay, thank you so much. Let me see if there are any questions for either of our speakers. Yes, we had technical glitch. Yes, we have come out of that. But any questions from anyone? Meanwhile, I'll keep asking few questions to our dietitian Tulsi. So see, when we hear about burns, so now either SJS or TENS, when we compare, it's almost like burns. So first thing that comes to our mind is for energy calculation, Curie's formula. But we also know it can overestimate. So did you attempt doing the calculation as per Curie? How much does it come, and actually how much did you give?
Yes, ma'am. Actually, I did that. I calculated and see, but it came approximate according to her weight. Actually, her weight was 54 kg. It came up to 2,550 kilocalorie. So her requirement, I felt it's approximate 1,900 kilocalorie. So we did normal calculation like what ESPN guidelines telling. That one I followed.
That way you said was 35 kilocalorie per kg body weight. Okay. And similar question in terms of zinc also. Again, when it comes kind of a burns patient, zinc is very much needed. And you said you supplemented. So doctor gave through the SIP-Me solution and you gave the feed. So how much were you able to meet up? What was the...
That also I calculated. Approximate I could meet 31 milligram per day. So yeah, from feed and both this supplement.
Okay, and how much actually is the requirement in such cases?
Approximate this case, TN case, 30 to 40.
Okay.
Very severe cases, 55. Burn cases, 55.
Okay. And I am sure this was quite a sensitive case. How was the person? How was the lady? Was she accept? First thing is mucositis. Swallowing even saliva can be very difficult. But acceptance of food, was she okay with the options you were giving?
I already explained. I think she was when I was taking history. She was very active person and she is health conscious also. Initially, I was trying to give oral semi-solid like this ice cream and all. She was not ready to take it. And slowly with counseling, she was accepting later.
Was it with the fear of weight gain?
Weight gain, yes.
Unfortunately.
Yeah.
Okay. And how is she now when you do the follow-up? I understand she doesn't come physically. It's, of course, with the dietitian, but she has been seeing the internal medicine doctor. How is she for interaction? You have...
Actually, she was coming to OPD, but I tried meeting her, but she was not ready to meet me. Through telephonically only, I could interaction with her husband. And still she was not recovered from psychologically. It's affected, and that's what she was not ready to.
Okay, fine. I have few questions here. Dr. Sandhya is asking, within how many days were you able to meet up the target energy and protein?
within 5 to 6 days, ma'am. 5 days I could.
Okay. Any more questions, Aisha? I am seeing in the comment.
Because she was able to tolerate feeds well. Also, we started with the semi-elemental formula and slowly, gradually introduced the polymeric formula. So we could achieve that.
Okay. And any diarrhea? Was there any problem?
Nothing was there.
Oh, thankfully. Otherwise, that
Yeah.
itself could be the
Yes.
major
Only thing
obstacle.
oral tolerance was less because of grade 3 mucositis.
All right. In audience, anybody has any question, kindly drop in. We'll be able to take up the question. If there are no question, it's 3:40. We'll log off the session if there are no more questions. All right. Thank you so much for the participation, for logging on and listening to the case study, because these are the ones which we always don't come across. And definitely it was quite a painful thing to see a patient suffering like that. Thank you. Hopefully we'll catch up again for more case studies in the future. Thank you so much.